These webinars are actually designed to provide timely information and demonstrations to support and guide the development of your telehealth program. These webinars typically are, as I said, on the third Thursday of the month. They're also recorded so that way you would be able to actually access this from our YouTube channel for future reference. I'm just going to start by going to our map to give you a little bit of context as to the resource centers. There are 12 regional telehealth resource centers and 2 national telehealth centers. The 2 national centers focus on policy and technology, and all of these centers are federally funded by the U.S. Department of Health and Human Services through Health Resources Service Administration, or HRSA, and that is connected with the Office of Advancement for Telehealth. And each of these TRCs serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. You can find our website address at the top of this slide. And as I mentioned, you can always go back and refer to past webinars and also to our future calendar of webinars. I'll just give out a few tips for the webinar before we get started. Your audio has actually been muted, and this will just help to eliminate any background noise or anything. But you can always type into the Q&A function of Zoom. It's actually on the bottom middle of the screen, and that's how we'll actually take questions instead of through the chat. And questions will be answered at the end of the presentations. And then in addition to that, today's webinar, as I mentioned, is also being recorded. So it's a great opportunity to go back and look at past webinars. If you wanted to capture some of the specific slides, you can also find that on our webpage. So without any further ado, we are very fortunate today to have 2 fantastic speakers that are going to discuss 3 perspectives of telepsychiatry: adult, pediatric, and direct-to-consumer. So the 2 speakers are Scott Baker, from the Business Innovations Manager at Insight Telepsychiatry, and also Barb Johnston, the CEO and co-founder of HealthLinkNow. And we're going to go ahead and start directly with Barb's presentation for telepsychiatry direct-to-consumer. So take it away, Barb.
Thank you. Okay, so let's go to it. I'm going to be talking about telepsychiatry and pretty much be commenting based on experience that we've had over the last 8 years with doing direct-to-consumer as part of our practice. The sections I'm going to highlight are who's appropriate, benefits, challenges to doing this, and then at the end you can ask questions if you'd like, or wait till the end of the entire presentation. It's fine with Scott and I, any way people want to do it. So next slide. So you do have to think about who are the appropriate patients to provide this kind of care at a distance for. And we screen out people who let us know that they have suicidal or homicidal thoughts. Those people actually need emergency services. And so if you saw someone in that condition physically in person in a clinic, you'd probably send them to an emergency room for emergency services, and so we screen them out. Most of the people that we see commonly have depression, anxiety, and a lot of our veterans with PTSD who really enjoy being able to see their physicians from home. We do make sure that our care navigators who do all the intake for these patients make sure that people actually have capacity, that we don't rely on people saying they can do a video conference. We do a little test to make sure they actually have it and have a camera and know how to connect. We want to make sure that wherever they are, patients do have a private environment. It's not appropriate for people to be connecting and communicating with a psychiatrist from a coffee shop, or if they work in a cubicle where somebody can overhear the conversation. It's not a good place. We've had some people want to connect to our doctors from airport lobbies. Not an appropriate environment. So you just have to take all those things into consideration and up front have that conversation when the patients are being screened and when the care navigator or intake case manager, whoever you're using, or even if it's a physician themselves setting these up direct themselves to make sure that they go over the need to be in a private environment for the provider as well as the patient that is being cared for. It's also important for people to have a backup. We make sure we have an email to connect with people and hopefully a cell phone in case there is a technical problem. We want to have a way to connect with them. We have always used informed consent. Our patients sign the consent. They do it online through the patient portal and document that. Every state has a little different approach to whether or not they need a verbal consent or if they need signed. So since we see patients in many different states, we just do informed signed consent, and that kind of covers all the bases for us. You do have to make sure that you're observing the rules and regulations for individual states because they vary quite a bit. And if you're seeing patients who are located in a foreign country, you can't assume that that means you don't have to abide by their country laws and regional laws because all the countries that we've gone into, they do have their own rules and regulations, so just be aware of that. So next slide. So Mike, can you advance that slide?
Sorry, having a technical difficulty here. I'm not sure why.
So while he's trying to fix the slide, I'll just tell you about the example on the next slide. It's just we took a very typical patient that we see, and it's a 35-year-old woman who has severe depression, and she, in an interview, the case manager was able to find out that she wasn't suicidal. She's actually a nurse who worked in a local community hospital. There were lots of psychiatrists that she could have seen. She didn't have a problem getting an appointment. That wasn't the issue. Her issue was privacy. She didn't want to see a psychiatrist who maybe knew who she was. She didn't herself work in the psych department, but she just felt like seeing somebody who worked at the same hospital was just not private enough. So that was her reason for reaching out to us. She also had a full-time job, worked till 3 o'clock, and then she has school-age kids. So her time was a real challenge for her. So she's actually finished up seeing with us, but she was seeing for about a year. And these were 3 quotes that the care navigator gave to me. They're direct quotes from this particular person, but they're very, very common. And we hear this a lot. She said that she didn't want people at work to know that she was seeing a psychiatrist. She also said that even after the very first video conference, that she felt it was more personal somehow than even seeing somebody in person, which I always find fascinating. But we do hear that a lot, and I'd like to know what Scott thinks later, because I have a feeling they hear this too. And she actually preferred being able to be seen on video than she going in person, physically in person. So next slide. So the benefits to patients, and these are pretty common. The care provided on video should meet the standard of in-person care, meet or exceed. That's always been our goal. More and more patients are expecting it. They ask for it. We have contracts with a lot of insurance companies who keep telling us this, that they're hearing this too more and more. It's just so common. We do video conferencing and so many different things we do in our everyday life. It's becoming more mainstream. It obviously allows a lot more flexibility for appointment times for people who work or busy in the daytime, or maybe the only time they can see somebody is on the weekend. So it really opens them up to access to care. It also is obviously less stressful if you're seeing somebody from familiar surroundings. If you're in your own home and you have a private place to have this conversation, it's just more comfortable. You don't have to take off work or school time. For many people, this is a really big issue. And for people who go on vacation or who are traveling for business, and they need to see their doc, they can connect. Still have to meet the requirements of whatever state you're in. You still have to, the doctor has to be licensed in the state where the patient is at the time of the consult. And the other big thing is just privacy. We do hear a lot about how they feel it's much more private when they can just see somebody from their own work site or their own home. Next slide. Providers, a lot of the benefits for providers are pretty similar to what we hear from patients. A lot of providers want to do this. The younger docs, they just expect to be able to do this. It's finally being taught in a lot more medical school, but telepsychiatry is anyway. It allows doctors to see patients at different times. We have several doctors who prefer to work evenings and weekends for personal reasons, so this really works well for what they want to do themselves. They don't have to travel either. Being able to see patients from your own office or your own home is a nice familiar surrounding for the providers also. Also, this is a different way to work. I think if I was a psychiatrist, I'd kind of like the flexibility myself, and we do hear that. There's no extra overhead for doing this. It's pretty simple to do. And probably the biggest thing that we hear is the providers tell us they know that the patients really like this, and that matters a lot. So next slide. So things to look out for, making sure that you have a private location. That's not always easy to do. Some people's home environment isn't conducive to doing this, so they might have to find another location. Some people work in cubicles or at the bank. You can't do this either, so that sometimes can be a real challenge. Patients sometimes change technology. We've had instances where the care navigators have set up and done a test, and then when the doctor comes on, you find they changed the whole thing. So what we've learned over time is when we're doing a test to make sure people have capacity to do the video visits, that we remind them, please don't change. Don't change your microphone, or don't try and improve things, because then it makes it impossible to do the consult. We used to have problems with drop calls, and then we'd be calling people on the cell phone trying to figure out what's going on. We haven't had that problem for about 2 years. We switched to a different system that's really simple, it's reliable, so we don't have that as an issue anymore. But some technologies, different video conferencing systems may be a problem, so just be prepared that you might want to have a cell phone, or, like I said earlier, email, some other way to reach people in case there's a technical problem. Getting buy-in from primary care is really, really important. If the primary care docs don't think this is a good idea, it is not helpful. Primary care docs, you may need to communicate with some of them if they're resistant. Most of them, especially more recently over the last 5 or 6 years, have become so familiar with it, it's been pretty easy to do that. Probably one of the big problems for any healthcare, let alone telemedicine world, is who's going to pay for it, how's that going to happen. Private pay is no problem. People pay for it, and that goes well. Insurance payers can be very challenging because you need pre-authorizations unless you have a contract. Most of the clients that we see, we have contracts direct with the insurance company, so they're pre-authorized and it goes smoothly. But if you're going to set this up, be really aware that you have to figure out who's going to pay, how's that going to happen. And then probably everybody on this call knows how important it is to know all the rules and regulations for the states, and they're not stagnant, they change. We refer a lot to the Center for Connected Health. They put out the TRCs put out fantastic information to help all of us in the industry keep up with the changes in rules and regulations by state. And then a big one that we have learned is really important is to make sure our providers are professional in how they present, including their the way they sit, the way they dress. They need to be just as professional when they're seeing patients at a distance as they would if they're working in a medical office. So you see the two photos at the top. We should be trying to look like the woman on the left and not like the guy on the right. You don't want to get too comfortable. That doesn't work well for patients. Next slide. Okay, so that's to the end, and we can do questions at the end. The only thing I wanted to end by saying is patients really like direct-to-consumer care. We don't seem to have to talk people into that. Our psychiatrists have to learn to like it. Eventually they do. Some are a little resistant to start with. And looking at health outcomes, which we've tracked for years, they're very good. So thank you.
Barb, would you like to take, we do have 2 questions in queue. Would you like to take those now, or would you like to?
Sure. No, it's fine.
Okay. So the first one is, where do you document the appropriate patient checklist for standard operating procedures?
We actually are accredited by the Joint Commission. So we have policies and procedures set in place for everything we do. We use Athena Health is our electronic health record that we use for all the notes for the patients.
Okay. And then the next one is, do insurances contract differently with different practices? Where can we find insurance telepsychiatry policies? What
we do is we directly contract with insurance companies and we negotiate the terms with them. So when we're talking with them, that's part of the whole negotiation process.
Okay. And then the next one is, can you please repeat the credentials and positions of both speakers? So that's on me. I'm more than happy to do that. In fact, I should have given a little bit better intro. So for Barb Johnston actually is the CEO and co-founder of HealthLinkNow and has over 20 years in the telemedicine industry. Ms. Johnston was actually the project director for CMS and CMMI award of $7.7 million, which integrated telepsychiatry services into over 80 primary care clinics across multiple states. Ms. Johnston has experience in the business, legal, clinical, and policy aspects of the telemedicine industry. So that's the background on Barb. For your next presenter, which is Scott Baker, he's the Business Innovations Manager at Insight Telepsychiatry. Mr. Baker is passionate about expanding behavioral health care access. He works with hospitals, clinics, insurance payers, managed care companies, EAPs, ACOs, universities, correctional facilities, and extended care facilities and other organizations to develop successful telebehavioral health programs. Mr. Baker collaborates with providers, executives, and regulators to design and implement quality telebehavioral health programs and frequently shares best practices through various speaking engagements. In fact, in the past, he has spoken at organizations like Open Minds and Mental Health America, in addition to leading webinars on the use of telebehavioral health in community mental health centers, universities, skilled nursing facilities, and more. So hopefully that answers your question. The next one, what video platform did you switch to that you actually like, Barb?
Yeah, we use Zoom, Z-O-O-M. I'm trying to be, historically we've been agnostic. You know, we don't have a conflict interest using it. I just want to make sure everybody understands that. But we've been really happy with this product. We found that not only is it simple and really effective nationally, but it was the one system that when we were seeing people internationally have never dropped a call. We've been really happy with it.
And then it looks like this is the final one that we just received. Do your providers e-prescribe, and how does that work for controlled substances?
We follow the DEA regulations. You can't do e-prescribing of controlled substances, but our system is connected to every pharmacy in the country. So our doctors use Athena Health, which allows them to do all the notes and do the prescribing.
Great, thank you. And Scott, we'll go ahead and move on to your presentation of how to be a telesuccess.
Okay, excellent. Well, thank you for the opportunity. It's a pleasure. Good morning to everyone out there, or good afternoon, depending on from what part of the country you're joining from. So it's a pleasure to follow Barb as well. Great content around direct-to-consumer services. Certainly it's a very exciting area of telebehavioral health. And we're excited, as I'm sure Barb and her organization are, to see really exponential growth and adoption of telebehavioral health in a direct-to-consumer format. My portion of the presentation will focus on some of the other common operational models for telepsychiatry. And I also want to touch on some of the associated implications of some of those different operational models for different populations, adult populations, geriatric populations, children, and some other special populations. And then no good webinar is without having some lessons learned in program planning and implementation. So next slide, if you could, please, Michael. Again, I understand I'm speaking to an audience that's largely tele-informed, if that's a phrase that I might coin. Many of you folks may be aware of this, but I will take every opportunity that I have to ensure that when we're talking about telepsychiatry and telebehavioral health, we're talking about psychiatry. Delivered through real-time face-to-face video conferencing. And so if you have a question, I would encourage you, of course, to ask it in the Q&A portion, but to first consider, is this just psychiatry delivered through a video conferencing medium? Fundamentally, we're talking about care that's possible through human interaction that just takes place through video conferencing. The next slide. And so again, given that many of you are informed and aware, you may have seen used or have used yourself telepsychiatry, telebehavioral health within maybe a hospital setting or a clinic setting. But I'd also like to highlight some of the other settings where telepsychiatry is commonly used across the care continuum. Again, clinic-based services within outpatient clinics are quite common. Barb already went through in-home services where a patient's at home in the comfort of their own private space to receive care. We're seeing a lot of adoption within primary care or generalist offices as part of, and I emphasize as part of, integrating behavioral health within physical health environments. Emergency departments will highlight here in a few moments with our on-demand model. That can also be applied within hospital med-surg floors. Inpatient units have been a tremendously large area of our practice over the past few years, as well as seeing urgent care clinics and mobile healthcare clinics see this as well. CMHCs, community mental health, federally qualified health centers are important points of the continuum of care that also struggle from access to adequate psychiatric resources, and we oftentimes find them to be eager partners to us. And then schools, corrections, and skilled nursing facilities. So apologize for reading the list, but I want to emphasize that these are not settings where you only see telepsychiatry applied here or there. These are settings where very commonly telepsychiatry is used and adopted. Next slide, please. We're equally excited to see telemedicine move into the mainstream. It's a process that we've seen coming for many years, as I'm sure Barb has with her tenure in the industry. You see different sources quoting 90% of health plans offering telemedicine options, or a similar, if not higher percentage of employers embracing telemedicine options. I think this is an important time to highlight some of the distinctions between telepsychiatry or telebehavioral health and some of the more physical health applications of telemedicine. And so when we talk about telepsychiatry, we're really talking about establishing an ongoing longitudinal relationship between a patient and an appropriate provider. It is, typically a course of care, depending on the setting. If you're talking about an outpatient setting, can be 8, 12 appointments a year or two, like Barb cited in her patient example, if not longer, depending on the complexity of the interaction. And oftentimes you'll see services covering prescriptive services from psychiatrists or psychiatric nurse practitioners, as well as therapeutic services and other points within the continuum of behavioral health care. When you look at other physical health applications of telemedicine, especially in the direct-to-consumer space, it's a little different. And I'm not saying that to highlight that one is better than the other. They're just truly different, such that engaging with some of these larger physical health telemedicine companies, the focus is on short one-time appointments. Let's address the issue and be done with it. You don't necessarily know what provider you're going to be choosing. It's more based on, state license and availability as opposed to expertise or, fit or preference of the patient. And it's oftentimes models more of an urgent care application. Next slide, please. So for the next few slides, I want to highlight some of our operational models. And I want to do so as a way of illustrating some of the opportunities, some of the choices that your program may have, as well as some of the clinical implications within the different special populations here. So the first is a scheduled services model. This is the service model here is integrating a remote provider within a system of care to see and manage a consistent caseload of consumers over a longitudinal point in care. Oftentimes, that means we are regularly scheduling blocks of time from a consistent provider within a single outpatient clinic. And what this allows is for real fit and integration between the remote provider and the team on the ground. And so if you remember back a few slides ago, we talked about settings for care. This scheduled services model is commonly applied within outpatient clinics, within community mental health centers, and within federally qualified health centers. The services provided, as you can see on this slide, are oftentimes the same services you would find in an outpatient clinic. Initial psychiatric evaluation, ongoing med management, therapy and counseling services. We also place a high emphasis on allowing the remote provider to participate in treatment team meetings and really be a part of the team, as well as providing group care, should group therapy be a part of that. Some of the benefits of a scheduled services model include scalability. We oftentimes will speak with organizations that really just need a few days a week to address the need that they have. And so as opposed to hiring a part-time provider, can use a telepsychiatry application to meet that need that's less than a full-time equivalent. Also bringing in expertise that might not be an FTE. Working in particular with a federally qualified health center who has a small population of children and adolescents who need child psychiatry services, but couldn't fill the schedule of a full-time doc. And again, a common theme that you'll see throughout here is tapping into expertise and access and availability of providers that aren't physically within the community where the patient is located. So adults oftentimes within a scheduled services model are interacting with a general adult psychiatrist or nurse practitioner or a therapist. Children, again, typically a child psychiatrist or a general adult psychiatrist who has some expertise or experience with children, and then therapists as well. Next slide, please. The next slide highlights the OnDemand model. This is actually the model where Insight got its start back in the late 90s in the state of New Jersey. And this is a service model where a team of providers are assembled into a coverage schedule and respond in an as-needed fashion. Sometimes this model can be 24/7, 365 coverage. Other times it can be, early in the morning to late at night or just overnight. There's a variety of different scheduling components, but ultimately the services provided with an on-demand model include most commonly triage in that ED, being able to have a psychiatrist lay eyes on a patient who's in an emergency department or a walk-in crisis clinic. And those services can also be moved upstairs to the med-surg floor to partner with a hospitalist to make clearance for disposition decisions or manage comorbid behavioral health conditions that might be on the med-surg floor. Oftentimes an on-demand model also involves commitment decisions, like involuntary commitment decisions, which can be different or are different in every state, or doing rounding on patients who may still be in the ED or on a med-surg floor. And ultimately, the goal of an on-demand model is, yes, it is to bring specialty expertise into a treatment team, but it's also to determine the most appropriate, least restrictive level of care for that patient. Anyone who's familiar with hospital emergency departments and that point in the continuum of care have heard about psychiatric boarding in the ED. It's really prevalent across the country, and it's a big problem. And using telepsychiatry in an on-demand model, it's not the panacea of ED boarding, but it is a very important part of the solution to get the decision made by a specialist in a more timely fashion. And a lot of people don't think about the concept of defensive admissions. Without psychiatric expertise in a hospital emergency department, it's left to the ER physician or social worker. And we hear all the time that they make defensive admissions because they're not equipped or have the time to make a disposition recommendation on a patient. And so they may default to sending to an inpatient or higher level of care just out of, to lower risk profiles or because they really don't know. You insert a telepsychiatry solution into this. Our psychiatrist is not performing CPR in the next room or stopping a bleed, that's coming in the door. We have a little bit more time to slow down, to review and collect collateral information, and use the specialty training and expertise to get that patient to the right level of care. What's very important in this model, again, as in all models, is knowledge of the community, knowledge of resources in the community, knowledge of resources within the facility itself, so that our remote team or remote clinician can truly act as a member of that medical community and make recommendations for services that are truly available within the community. For adults, most commonly this application is to reduce boarding in the ED or to get admissions processed quicker or discharges processed in a more timely position. And again, children oftentimes are very impacted if they're held in an ED for a prolonged period of time. The next slide, please. So all of what we've been talking about thus far has been synchronous telepsychiatry, real-time face-to-face video conferencing that really mirrors an interaction that you would have if the clinician were physically there in person. Asynchronous is a bit different. And I won't overspeak to this one because we really don't do asynchronous in our organization, but have learned a lot about it over the years. And I think Barb has probably more experience than I do with this. But to highlight asynchronous, it's store and forward technology. Oftentimes it's more in a interview, review, respond format. It's, to my knowledge, more commonly used in the more far-flung regions, Alaska, other regions where a trained interviewer will record an interview with a patient and then send that to a specialist like a psychiatrist who can review and make recommendations in responding. Oftentimes these services are a bit more consultative in nature and truly designed to support the generalist. Next slide, please. The direct-to-consumer model is the next slide. We've heard a lot about it from Barb, and I'm excited because I think we'll continue to hear a lot about well-intentioned, well-designed, deliberate applications of direct-to-consumer telepsychiatry as a part of the solution for health plans to meet network and access gaps, as well as a part of the solution for other points in the continuum of care, which I'll talk in a few more slides. So we'll move on beyond that since Barb did such a great job outlining the direct-to-consumer services. And so I've tried to sprinkle some benefits throughout describing some of these operational models, but I want to take a moment here to do a similar thing that Barb did, which is to pause and reflect on the benefits from different perspectives. And so ultimately, we do what we do with the consumer and the patient in mind. And so the benefits to the consumer, depending on the operational model, you're going to see common themes of reducing time and improving access because you're able to provide services when and where the patient actually is when they need the care, bringing more specialty expertise in, and flexible hours. Barb commented on something that we see in our practice as well, which is providers that like to work weekends and nights. Well, guess what? Weekends and nights are oftentimes the most common appointment time slot that is requested by our direct-to-consumer practice as well. You consider a busy parent who just finally puts the kids to bed and is able to then engage with a clinician, or a shift worker who doesn't have the luxury of being able to see their clinician or psychiatrist during regular working hours. From the consumer, telepsychiatry can also help facilitate that continuity of care. To date, thus far in this presentation, we talked about telepsychiatry in specific operational models. But the part that's missing is how telepsychiatry and telemedicine in general can flow between those typical points in the continuum of care. And for a health system, if there's anyone attending this webinar from the health system, your brain might already be going towards different applications. And from the consumer's perspective, should they be able to see a psychiatrist through telemedicine, ED, or an inpatient unit, and be followed and supported by that clinician until they squarely land in a community setting, can be valuable not just in terms of preference and comfort, but also in terms of clinical outcomes. From a telemental health provider's perspective, comfort and convenience, right? But that's why everybody does telemedicine. I think there's there are benefits beyond comfort and convenience. Everyone knows about the shortage of workforce within behavioral health care. I won't preach to the choir on that one, but by bringing telepsychiatry as an option into the total body of clinical work that a provider does, actually squeezes out more availability. We have plenty of providers who quote that they would have retired should they not have been able to move to Florida and still see patients in another state that they're licensed. Or a parent who says, you know, I just want to take off a couple of years and be with my kids. Well, you introduce telepsychiatry, and they have that opportunity to still do what they love with their clinical work, but also be at home with their children. Now, obviously not at the same time, but flexibility with new parents as well is important. And so there's other clinical considerations as well, because a lot of psychiatrists, and this may not be unique to the behavioral health profession, but like to engage in different types of work. Somebody who's stuck in outpatient work for 20 years gets burned out or gets bored of the routine. Again, a generalization. Somebody who's working moonlights in the ED can get burned out by the shift work and the constant shifting nature of it. And so we do find providers will commonly engage with our practice at multiple points with multiple operational models and really feel engaged to do the type of work that they feel is within their preference and within their expertise. And within the community, we'll talk a little bit about this more in a few slides, but the community of care here is a concept that's becoming more and more top of mind. And I think it represents a lot of positive trends within behavioral healthcare and healthcare in general, which is bringing behavioral healthcare into the picture sooner, addressing behavioral healthcare needs and screening for them proactively and addressing them in the moment so that your patients don't end up seeking care in the ED. They can get it at a more appropriate level of care in an outpatient setting or even in home. And telebehavioral health can also help reduce silos, right? So telepsychiatry can bring resources into each of those silos, the ED, an outpatient clinic, a college setting, a correctional organization, but it can also help as a bridge between those. As we know patients flow from one silo to another, what happens in between? So let's also talk about challenges, because it wouldn't be fair to talk about the benefits without the challenges. So next slide, please. And I'll actually start by addressing some of the challenges with providers. Licensure, number one challenge. Number two is probably credentialing and medical affairs, but let's not get ahead of ourselves. We still have to be licensed. The provider still has to be licensed in the state where the patient is physically located. And that creates cost, complexity, and delays from an organization like HealthLinkNow and Insight that practice in multiple states, because our providers like to be able to impact multiple communities, but have to maintain multiple licenses should those communities be in different states. We do continue to be excited about and really happy to see advancements with the Interstate Medical Licensure Compact, and hope to see similar advancements within the scope of work for nurse practitioners as well. Also, a challenge with providers is not to feel isolated or on an island. When you're working from home, everybody says how great it is. But what people oftentimes don't think of is how lonely it can be as well. And so provider engagement is a piece that we find to be very important, because clinicians need to grow through collaboration with other clinicians. They need to be able to, meet around the water cooler, knock on a colleague's door should they have a tough case. And so that is a challenge with telepsychiatry providers. And it's important to ensure that they remain engaged with one another and with advancements and developments in their field. Working within disparate operational models or documentation models, that can be tough. EMRs are, we still have not seen any true integration or integration tools among EMRs. And so for an on-demand provider, they at times may need to shift between different EMRs. And one of the final and maybe one of the more important considerations and challenges for providers is knowledge of the continuum of care in the community they're serving. If you have a provider living in New York City, serving a patient in upstate rural New York, that provider is expected to and needs to know the cultural considerations within that community, the resources that exist within that community, emergency resources in that community, to be able to do a fair and good job of delivering high standard of care, quality telemedicine services to the patients. Shift gears over to the left side of the slide with programs. Barb's already talked to the state and federal regulations. It's important, yes. There are resources out there that Barb highlighted with CCHPCA, with the American Telemedicine Association, and others that do a good job of staying abreast of and helping to communicate those federal and state regulations. And I think it's important also to consider designing the efficient workflows and getting buy-in for this program, which is something we'll talk about here in a few slides. But I want to make sure that we get through some of the other content specific to the populations as well. So, Michael, if you could advance 2 slides, please. So let's start with children as a special population. And so in terms of behavioral health, oftentimes when we're talking about children and adolescents, we already know that there's a severe shortage of child-adolescent psychiatrists. And so that just exacerbates the issue and actually shifts the burden of care to pediatricians, primary care physicians, other generalists. Children oftentimes in the behavioral health continuum are suffering from ADHD, OCD, mood and anxious disorders. They're prevalent and they're complicated, and oftentimes impact the entire family. Diagnosis can be tricky, and treatment can evolve as the child matures and grows. And so with telepsychiatry, it's important to have a balance in working with the child themselves, working with the parents, working with the teachers. Now, some of the benefits of working with children within telepsychiatry is orientation. They don't need to be oriented to the technology as much as an adult population does. They're already accustomed to that technology interaction. And oftentimes, some of the settings that we interact with children are in the outpatient environment, pediatric multi-specialty practices, residential programs, and inpatient. Quick story here, less than 30 seconds to tell this story. Our owner and medical director, Dr. James Burrell, shares a story with our organization of a child who was complaining of stomach pain and had been to a number of pediatric specialists, had a lot of imaging and x-rays done, had eventually gotten to a therapist because nobody could figure out what was going on. Didn't open up to the therapist, ultimately got admitted to a facility, a behavioral health facility, where Dr. Burrell saw him through telemedicine. And when he came onto the screen, he was covering his head with his sweatshirt, not engaging with the screen, not engaging with the facilitator in the room. And when Dr. Burrell started speaking through the video conferencing, he opened up. He removed his sweatshirt from his head, and it was probably the novelty, right, of the video conferencing to start. But it also could have been a little bit of not being judged by an older white man in the room, as this was an inner city youth who, may have felt judged by the system already. And through the course of that and subsequent interactions, it came out that this individual had seen his brother or friend, I can't remember who it was, been shot in the stomach and was having referred pain. And so through telepsychiatry, we were able to actually finally get him to engage in treatment and to get better. And that's just one example of how children are impacted by telepsychiatry. The next slide is aging adults, right? The golden tidal wave, if you will. And this is a special population to consider as well in terms of using telepsychiatry. Orientation with technology is very important. You must establish trust. You must allow time for questions up front. Are you a real psychiatrist? Is this being recorded? There's a lot of fears within this population with receiving care through telemedicine. Sound is important as well. Can they hear you? Our providers are trained to speak slowly, very distinctly, loudly. Sometimes the technology needs to be turned up on the other end where the patient is located. There's also clinical considerations with addressing this population. Oftentimes older individuals with mental health conditions have comorbid physical health conditions that can be complicated. And so this is an excellent opportunity to highlight the importance of communicating and sharing documentation as appropriate with other providers in the physical health continuum. And so, that allows us to better make medication recommendations or decisions and ensure that we're sharing information and treating the whole patient. A lot of times, the settings where we encounter aging adults, skilled nursing facilities, assisted living facilities, an internist office, in-home is also not an uncommon location to provide telepsychiatry to this population, as well as geriatric inpatient units. The next slide, please. And on the next slide, we'll talk about autism as well. Autism is an area that's, again, woefully underserved And I've seen some exciting research of applying telemedicine and telepsychiatry to addressing autism spectrum disorders. Oftentimes what we've seen, and this might just be one model, but is an application where a BCBA level professional does supervision of field personnel who are interacting with family or caregivers and the patient, and is able to be on a Bluetooth device in the ear of the patient or the caregiver giving coaching. And also, in the absence of having the trained personnel there, the BCBA to be able to monitor or to not interact with, but to observe in-home interactions and be able to continually support and coach parents or caregivers in the treatment of autism spectrum disorders. English as a second language. Again, the best option is to receive care in the native language, and telepsychiatry might bring providers into that community to provide that service in that native tongue. But there's also cultural considerations as well. And we approach these communities the same way with language and cultural considerations as we do resources in the community. And we seek to get an understanding of, from the boots on the ground, what the needs are, and train our providers appropriately. We've also seen some and used some integrations with language translator services, sign language services. All can be adapted to a telemedicine modality. And the last one here is indigent populations. Indigent populations suffer from behavioral health at a higher rate than non-indigent populations, and arguably may need the services more because of that prevalence. And it's very important to ensure that they have access to the equipment and to a secure internet connection. When we see equipment, it doesn't have to be anything fancy. This could just be a computer or a laptop. A mobile device could work, but it's probably not a great experience. And a strong internet connection doesn't have to be blazing fast speed, but it does have to be consistent and dependable. But oftentimes in an indigent population, we spend a little bit more time making sure that they do truly have access to a private space free of interruptions, because we want to ensure that their experience with telepsychiatry is the same or as close as possible as they would have if they were seeing an in-person provider. And so the next slide, please. Patient appropriateness is a big point of education that needs to be emphasized. And Barb gave some great examples during her portion about who's appropriate and who's not appropriate. So I'd like to emphasize some of those points and maybe add some additional ones as well. Some states require consent or sign off, but regardless of the state's requirements, every patient should be educated on what telepsychiatry is and what it is not. You also not only have to educate the patient themselves, but the stakeholders who are helping to make decisions on patient selection. In an in-home environment, oftentimes you need to make patient selections based on acuity, previous medical history, previous psychiatric history. In an ED setting, you may need to make patient selections based on medical clearance or intoxication levels. And so it's important to educate here and make appropriate patient selection decisions. And the next slide. And so the next slide emphasizes the point that I alluded to earlier, which is behavioral healthcare does not exist in a vacuum. And we continue to be encouraged by growth in programs such as behavioral health integration with primary care, advancements in addressing comorbid physical health and behavioral health conditions, and reducing stigma for behavioral health and improving access to care. But it's important to realize that patients flow through this system with different frequency, with different acuity, and they take different paths through this example that's on this slide of different points in the continuum of care. Telebehavioral health has applications within each and every one of these, but there's also telebehavioral health applications to provide value to tie these together, to support a patient as they transition from one point of care to another. That's how we can truly create a connected community of care. I have about 60 seconds, and so I'll ask you to advance just 2 slides, and that'll be the final slide for my presentation. Actually, one up. Sorry, Michael. We're doing the slide dance here. When you're planning for a program, it's very important to consider a lot of the factors that we've already talked about here. But I'd like to emphasize that you should not approach telemedicine programming differently than you would to adding a new service line to your program. You have to ensure that stakeholders are engaged, and that doesn't just mean behavioral health stakeholders. Talk to the psychiatrist, the social workers who may already be in the system, but also engage the physical health providers like an ER physician or a medical manager in how they may utilize the service. And I think what you'll find is that the applications go beyond what you had originally envisioned. Don't be mystified by the technology or the reimbursement, because as Barb already shared an example, technology is not the crippling factor anymore. It's not the expensive factor either. There are applications of technology that are flexible and cheap, and they work better than anything that we saw a couple years ago in this industry. And from a reimbursement perspective, you're not walking into McDonald's and ordering a Big Mac. You have to walk in and prove your worth. And so Barb highlighted it, and I'll echo it. Measure your outcomes, know your data, and be prepared to tell your story. You're going to find a receptive audience with a lot of these payers, but not just because you have an idea. You have to go in and you have to have a well-informed telebehavioral health strategy as part of your entire solution. And so I'll step off my soapbox. Thank you again for the opportunity. I'd love to hear if I sparked any questions or if Barb has any lingering questions from her presentation as well, but thank you.
Thank you so much, Scott. And yes, there are questions. The first one is, what telepsych platform do you use, and can you comment on HIPAA compliance?
Absolutely. For our direct-to-consumer services, we use a platform called Empathy, spelled with an I, I-M-P-A-T-H-Y. It's a platform that we built ourselves. And just as Barb highlighted that they use Zoom, we use a different video conferencing technology that's open source called WebRTC. That's the video conferencing component of our broader platform. It also integrates services like scheduling, billing, care navigation. HIPAA compliance, it's the ante into the game. We have to be audited every year and be able to provide certification of passing that HIPAA compliance audit. It's not just the platform that's HIPAA compliant. I think everybody needs to be cognizant of that. It's also your operational model that needs to be there to ensure HIPAA compliance. I hope that answers the question.
The next question is, with patient safety in mind, is there a level of condition, anxiety or anger, for example, where telepsychiatry is not recommended?
It depends on the setting. So when you're in an in-home environment, you have to be cognizant that this patient is, they're not in a medical setting. They don't have the supports around them should the patient decompensate. And so if you are dealing with an individual who's made homicidal or suicidal threats, who seems angry and not engaged in treatment, that's a tough choice, and you need to dig a little deeper to determine if they'd be appropriate to receive care from home. If you're talking about an outpatient clinic or a hospital setting, you take the same precautions and make the same decisions you would if you were about to put a psychiatrist in a room with that patient. Just because you're delivering the care through technology doesn't necessarily mean that it's different. And so you don't just slide the laptop under the door and hope they work it out. It may need additional facilitation. It may need some time. It may also need more than one provider to address the patient. Bring in a therapist or social worker, include security in the room. It really just depends on the setting, but there's not a clinical presentation that is de facto inappropriate for telebehavioral health.
The next question is, what are your thoughts about requiring in-person visits before transitioning to telehealth?
We're going to talk about abortion next and illegal immigration. No, that's one of the that's a topic that has been widely talked about throughout our entire industry. And I think what's important when you're answering that question is, what is the standard of care for delivering telemedicine? What is the standard of care for delivering behavioral health care and psychiatry services? And so if you have a valid answer for why a provider needs to be in person, and it can't be done through a telemedicine modality, then the conversation can continue. What we have found is that delivering services for a new patient through telemedicine is acceptable, it works, and so that's our position on it. Barb, I'm sure you have an opinion as well.
You know, this question has come up so many times. I work with our legislature here in California and with the federal government. And I usually turn that question about and say, why? and they kind of stop. And it's just a matter of thinking through it. It actually makes no sense. There is no reason to do the in-person visit first. And I think as has turned out recently in Texas is probably some of the most significant arguments. They've finished with that battle. They're done with it. And if anybody wants to find out what the challenges were, probably some of the postings from Nate Lackman, who really explains what their concerns were. But no, it doesn't make any sense to me. It never has. But I think the question's valid. I think the people who are asking are just wanting to make sure that whatever we're doing, we are providing quality care. So the questions are fine. I think that battle is kind of behind us as far as I'm concerned.
And Michael, if I could add to that as well, it's actually one slide up, but you probably don't need to go there per se. There are standards and guidelines for this that have been established by the American Telemedicine Association, the American Psychiatric Association. So, there's been a lot of research, a lot of work that goes into what is an effective telebehavioral health program in these different settings. And if you're providing telebehavioral health in a vacuum on its own, not seeking to connect with generalists or facilities, not seeking to share information with consenting patients, then the question is even more valid. But if you have a good quality practice that knows behavioral health and delivers it well, then the in-person question is much less of a concern.
I know we probably only have a time for a couple more questions, and then we'll be at the hour. But so Scott, the next question was for you. It says, Scott, has Insight done any work in the opioid epidemic and how either live telehealth or asynchronous model might work better for this?
Boy, yeah. So I'm not sure that I would say better, but I would say that with substance abuse, with substance dependence, mental health is so closely correlated that it's important to bring access to care directly to where that patient is. And we, for a long time, as I'm sure Barb's group has as well, have worked with communities that are hard hit and very impacted by opioids and other substances. And this really is truly an epidemic. And so there's nothing fancy. There's no secret sauce about what we're doing to address it. It's just bringing providers to, with the opioid epidemic more specifically, bringing more provider access to the entities that are already identifying and addressing this. And just one program that I'll highlight is a mobile PAC team that goes out into the community and meets with patients who can't or won't come into a clinic. Being able to bring a substance abuse professional or psychiatrist with that addiction expertise into the community to meet where that patient is in a facilitated environment has had tremendous improvements in getting that individual to engage in care.
It looks like maybe we'll have just one more question, and then what we'll have to do is the remaining questions, I'll make sure to get to the presenters and then give responses to these. There's three other questions. But the last question is, what agency do you use for your annual HIPAA compliance audit?
I do not know. Great question.
So this is Barb. We're a subsidiary of a large company, Universal Health, and that's all managed internally.
Thank you. And just finally, the last note that I want to thank both presenters. Those were great presentations, and I think everyone on the call really learned a lot. And I think that, like I said, I'll follow up with those additional questions because I just saw we just got 2 more questions in. So I'll follow up with Scott and Barb to get answers for those remaining questions. And then the only other thing I just want to remind you is for all the attendees, thank you so much for participating in the webinar today. It's a part of the National Telehealth Webinar Series. And as I had mentioned earlier, it's the third Thursday of every month normally. And the next webinar that we're having is going to be on November 16th. It's hosted by the Upper Midwest Telehealth Resource Center. The presenter is Karen Lee, who is a VP of the Rural Healthcare Program at USAC, and her topic is increasing connectivity for rural healthcare facilities. I'm sure this is going to be a fantastic presentation that you don't want to miss. And as I mentioned before, We are happy to provide these slides. I know that there were a couple of comments, and these will be posted to our website. And then the final note is your opinion actually really is valuable to us. So if you can participate in the survey, we greatly appreciate it. It really just kind of helps us to know if we're covering the topics that you want to cover, if there's anything new or additional that you'd like to have us change for future webinars. So thank you so much to Scott and Barb. Really appreciate all of your help. Thank you for everyone attending, and thank you once again, and wish you a good day.